James.
Hi.
Do you mind if I examine your
absolutely.
face today?
Sure.
Okay. So the first thing after seeing that a patient has a facial injury is to rule out any other fractures. Okay. There's about a 10% correlation with spinal and head injuries. So you want to make sure that there's no loss of consciousness. You want to make sure there is no underlying head injury. You want to palpate the spine or have the trauma team leader or someone ensure that the spines are cleared prior to focusing on the facial bone, okay? Because the facial bones can be fixed up to 3 weeks later without too much difficulty, but a missed spinal injury or head injury obviously is much more critical, okay? So, assuming that that exam is negative and we're just dealing with an isolated facial bone exam, we start mostly again with just a simple inspection, and you're looking for areas of bruising, swelling, any lacerations, and then after that I usually move quickly to sensation. So again, we're not looking at the cranial nerve exam, but we're looking at where those nerves come out, okay? So most of the time we're talking about cranial nerve 5, but what we want is basically their point after they're taking off from the foramen, because when those nerves come out of the foramen, those are weak spots in the bone, and classically facial fractures will go through those foramens, and so the patient will get numbness in those nerve distributions. So one of the best ways of determining whether or not there's actually a fracture is by testing sensation. So first off, we test the forehead sensation, and again we test both sides. And you feel that on both sides, okay? And that's usually the supraorbital nerve that comes out a little foramen on the top of the orbit, and it comes up and it supplies sensation to most of the top of the head. And so if there's a frontal bone fracture or supraorbital rim fracture, then you can get some numbness in there. Pretty uncommon, all right? Much more common is sensation here, okay? And then you test sensation over there and ask the patient for any numbness there. And that is your infraorbital nerve, and that nerve comes out of a tiny little foramen in your zygoma. And any zygoma fracture typically will involve that nerve, and the patient will get some numbness in their cheek, and it also can affect the numbness on the top of the teeth. So I typically ask, do you feel like your teeth are numb in the top? And then finally, for the nerve supply, is test the lower face, okay? And you test the lower lips on both sides, okay? If you can feel that, no numbness there, okay? And that's the mental nerve. And the mental nerve basically comes out of the mental foramen of the mandible. And within the mandible, it runs as the inferior alveolar nerve. And if the mandible is broken either through the foramen or anywhere in the body where that nerve is traveling, then that nerve will be bruised, and it'll cause numbness in that associated area. So that's a great way, if you see that numbness in any of those areas, automatically you're thinking, there's likely a fracture, and that fracture is likely going either through the foramen or somewhere where that nerve is, okay? Next thing is you want to test the patient's vision, okay? And the vision should be tested with gross acuity if you have an eye chart, okay? In a more acute setting with facial trauma, definitely, you want to make sure that they can count fingers. How many fingers there? 2. Okay. On both sides. 2. 1. Okay. So you want to do a gross acuity test. You likely want to shine a light into the eye and test your pupillary reflex. But more importantly for the facial exam is we're trying to rule out an orbital floor fracture here, and we want to make sure that the eye is moving, okay? And so I'm going to hold your chin steady, and I want you to just look at my finger. How many fingers do you see?
1.
Perfect. Okay, now just follow my finger. And so during this, you're examining the eye to see basically how it tracks, okay? And it should be tracking nicely. And at the end, you should ask the patient, do you have any double vision during any of that?
No.
Okay, so you want to make sure there's no diplopia. Okay, so there you get your subjective and your objective. If there's an orbital floor fracture, then sometimes it can cause swelling of the inferior rectus muscle, and then that muscle doesn't work as well, and so especially on looking down, okay, the patient doesn't move their eye symmetrically and they get some double vision, okay, and that's a hint that there could be an orbital floor fracture. Some orbital floor fractures, more commonly in the pediatric patient population, can actually entrap the muscle, okay, and in that case the eye does not move at all, okay, and if you see that on your exam, That's much more of an acute problem because if that muscle is actually entrapped, it is ischemic, and that is an emergency to get it undone. But those aren't eyes that just move poorly. Those are eyes that are quite fixed. And one of the other ways that you can determine whether that eye is totally entrapped is by putting some tetracaine drops in that eye you're worried about, and then doing what's called a force-duction test, where you actually take a pair of pickups with the eye anesthetized, and you actually pull up to see whether or not you can actually move it. And if it's fixed, okay, and the patient can't look up, okay, then you know that there's an entrapment of that inferior rectus, and that's something that needs urgent treatment. Okay. The next most critical thing is your occlusion. Okay, so we want to always get objective and subjective. Okay, so first off, I'm going to ask you, when you bite down, how do your teeth feel like they fit together?
Good.
Same as before your injury?
Yeah.
Good, okay. That's usually the best, okay, because patients with normal sensation in their mouth, okay, you know when you have a little tiny grain of something in your teeth, you can feel it. You can feel how it makes your teeth go off. We're very sensitive to how our teeth come together. So if the patient tells you that it fits together perfect, then usually you know it's pretty good, okay? But you always also want to take a look, okay? I'll get you to open your mouth up for me. I'll put my fingers in there and then bite down, okay? And I can see basically the teeth come together very nicely, okay? You have a very, very mild class 2 occlusion, but you can see how your bicuspid grooves and everything come together beautifully, okay? And so it's a nice occlusion, okay? So bite down again for me. Great, okay? And now open up again for me. So once you're in the mouth and you have your gloves on, you might as well finish your exam in here, okay? You look for any bruising in the mucosa, right? Any potential. If there is a mandible fracture, sometimes you can actually see steps and gapping in the teeth, and so you're looking all through there. If there is a hint of a fracture in here, a lot of classical teaching will wonder whether or not that fracture is stable or unstable. So you can actually get your 2 fingers on both sides and see if you can rock the fracture, whether it's a stable fracture or an unstable fracture. That can be quite painful for the patient, so we definitely kind of want to get permission to do that if you think there is a fracture there. And then the last thing while you have your gloves on is you want to look for a Lefort fracture. So a Lefort fracture is a fracture of the maxilla, okay? And the maxilla has certain pillars, and we call them the lateral and medial buttresses. So first off, you want to examine those buttresses. So you put your finger up, okay, just on the side of the nose, and that's the medial buttress on the left side, and you palpate that and you feel if anything's tender, okay? And then you move your finger over to the lateral buttress, okay, which is basically right where it starts, right, that kind of prominence right before it drops off on the inside of the mouth, and you feel that, and if that's sore at all, okay? And so medial buttress, lateral buttress, and you do the same on the other side, okay? And then lastly, okay, you basically see whether or not their midface is stable. So I get you to open your mouth again, a little bit less, okay? And here you don't want to grab the teeth, because sometimes patients will have dental fractures and their teeth will be loose, and if you start wiggling that, all you're picking up is whether or not they have dental fractures or not. So you want to grab above the teeth in the alveolar process of the maxilla, okay? And at this point, you basically want to rock that, okay? And the Lefort 1 fracture, which fractures down low across the lateral and medial buttresses on both sides, that can be quite unstable, and you can actually appreciate that whole upper jaw being quite loose. Lefort 2 fractures is a fracture that goes through the lateral buttresses and then up through the orbital rim and across the nose. And in those cases, okay, you can feel for maybe a little bit of rocking at the top of the nose over there, but a lot of times that's more just the patient's going to tell you it's more tender. First off, I always start around the orbits, okay? And you start by gently palpating around the orbits, and you ask the patient if anything's tender, okay? Okay, one of the common places like goma fractures are going to fracture is through the inferior orbital rim, and so you can gently press along the inferior orbital rim for tenderness, and if the patient does state there's some tenderness, then you can push a little bit stronger after telling him you're going to, because you can actually sometimes feel a step, and if the bone is broken and displaced, there'll actually be a step in that location. specifically when you compare it to the other side. Okay. The other place you want to palpate, okay, is along your zygomatic arch. Okay, your zygomatic arch basically runs right kind of in this location right over here. Underneath that is your temporalis muscle. Okay, and that's why people have an isolated zygomatic arch fracture. They'll sometimes complain that they're having troubles chewing, or they'll have some trismus because that temporalis muscle runs underneath of it, and if it's pushed in this location, it can actually partially impinge that muscle and cause some problems with chewing. So no problems with chewing? No. Okay. But more importantly, you can feel that, and again, feel for any tenderness and feel for any displacement there. Okay? And those are the main ones, and then the nose. Okay? So the nose you kind of want to again take a look at, all right, and you want to make sure the nose is nice and straight. Okay, and you can palpate that to feel if there's any tenderness on the sides. Okay, and most importantly, you want to get an otoscope and you want to take a look inside the nose. Okay, because you want to rule out any septal hematoma that may have developed. Okay, from the blunt force injury, and that's important because that hematoma can cause vascular compromise to the septum, and if it's not drained, then the septum will dissolve over time and the patient will get a saddle nose deformity, which is quite hard to fix. So if you're at all thinking that there's a nasal injury, you want to take a look inside the nose to rule out a septal hematoma. Okay? And then finally, I like taking a look at the patient from behind to basically see whether or not you can visually detect displacement in the zygoma itself. And so what I end up doing is I stand behind the patient, okay, and I want you to just tilt your head back just a little bit, okay, and so from behind here you can really get a good idea of the prominence of the malar eminence, and again, if it's a significant zygoma fracture, then this will be pushed in, okay, compared to the other side, and you can also get an idea with the patient keeping their eyes open, okay, of the position of the globe relative to the orbit. So if it's a massive orbital floor fracture, the eye will sink in, and that's called anophthalmos. Or if there's some significant bleeding, the eyeball will be more prominent on that side. And the Hertel exophthalmometer is the best way of looking at that, but in the acute setting, this works great in ensuring nice symmetry between the position of the globe and position of the malar eminence. And from here also you can get a good idea of the zygomatic arch as well. Okay. So that concludes your facial bone physical exam. Great, thank you. Thank you very much.